Assalamu alaikum dear doctors. In this video I am discussing a video station as there is no any video I get or available, so we use these pictures. So the task is that this is a 10 years old boy with moderate intellectual impairment and behavioral problems. Look this baby boy pictures, and now what sign we are observing in this pictures or video, that I can see a 10-year-old boy who is look pink in room air, and I can see he's short for his age. He is obese, and I can see he has gynecomastia. I can see distended abdomen, short stubby fingers, and in picture B, the child is look sad, and maybe there is mild hair, alopecia, and double chin, which is a sign of obesity. Picture C, it is showing that short and stubby finger, and picture D is showing cryptocerism. So what is my diagnosis? My diagnosis, that is short stature with obesity, which is evaluated further for findings the exact cause. Now, what are the differential diagnosis can be present? So differential diagnosis, we can say that Pradder-Willi syndrome. Pradder-Willi syndrome is associated with short stature and obesity, also intellectual impairment and behavioral problems. Other, that is Bardet-Biedl syndrome. There is unlike, because in Bardet-Biedl syndrome there is polydactyly presence, and there is eye problems, that is retinitis pigmentosa, and renal dysfunction presence. Now, endocrine causes, that including growth hormone deficiency, hypothyroidism, pseudohypoparathyroidism, Cushing syndrome, and prolonged use of steroid for any chronic illness, nephrotic syndrome can be. Now, what are the important history we have to address in this? So I will like that, if that he is short from his birth, is that any drug parents giving prolonged time, is there complaints of not growing in proper centile, uneventful event in neonatal period like hypoglycemia, any fit. Now tell me one diagnosis with neonatal hypotonia. So if one diagnosis we can go, then Pradder-Willi syndrome we can choose. So for Pradder-Willi syndrome, what are the history we will take? That is, how is his appetite, is there any sleep disturbance, how is coping at the school, how is his study going, require any neonatal resuscitations, and what about his development and growth chart. So other history we can ask, like history of diminished fetal activity, was he sucking properly during infancy, which means they may have feeding difficulties, underweight prior 1 year of age, is he required to be fed with a feeding tube, floppiness during infancy, has a weak cry, developmental delay, and excessive appetite and overeating, behavioral problems such as temper tantrums or stubbornness, and learning difficulties. These are the history can be present. Next question is that what are the important examining you want to this child? That plot his growth chart, height and weight, BMI for obesity, which is increased more than 99 centile, and growth chart show less than 3rd centile. He has sign of obesity like gynecomastia, cryptocerism, and also hypotonia. So if the case is that is Pradder-Willi syndrome, so what features we will find? That is short and chubby fingers, almond eye, that is a kind of small eyes, and other look physical features I will do. Speech articulation defect, almond shaped eyes, crossed eyes, eye examination for myopia and esotropia, a narrow forehead at the temples, narrow bridge of the nose, straight ulnar border, unusually fair hair, skin and eyes, and genitalia examination which expected to be small. Next question. 5 investigation like to do in Pradder-Willi syndrome. That is sleep study, as obstructive sleep apnea is developed in Pradder-Willi syndrome. Sign of obesity, we can check the lipid profile where we can find increased triglyceride level. To look for the fatty liver, we do ultrasound of the abdomen, and with cardiac complications, we can do ECG, echocardiogram. And for cryptocerism, any other endocrine, a full blood count, electrolyte, sugar level we can do. What is the diagnostic confirmatory test? Is that fish study, genetic study we can do for diagnostic test. Other testing, how I confirm this syndrome, by methylation study, fish study, uniparental disomy, UPD study, CGH microarray, and karyotyping. Now, what are the causes of Pradder-Willi syndrome? We know that 3 types of genetic syndrome, 75% deletion mutation most common, and others are methylation and uniparental disomy. So 3 types, that is deletion, methylation, and uniparental disomy. Which chromosome is involved in Pradder-Willi syndrome? That is 15q chromosomes. Remember, Prader-Willi syndrome is a mama's boy coming from the mother, and this opposite of Prader-Willi syndrome is Angelman syndrome, and that is coming from papa. Remember one thing, both boys and girls are there is no any differentiation, all can be affected. Now the question is that what type of radiological study you want to do in Prader-Willi syndrome. So radiological study, we do X-ray to look for osteopenia as obesity present, X-ray of the bony limb, because differential diagnosis is pseudo-hypopituitarism, and obesity we can do SUFI, sleep upper femoral epiphysis, radiology of the hip we do, and ultrasound is important for fatty liver. Baseline investigation we do lipid profile, random blood sugar, obesity related cholesterol, blood test, these are, and follicular stimulating hormone and luteinizing hormone level we can check. And complication of Prader-Willi syndrome including obstetric sleep apnea, that's why we know sleep study you do, cardiac problem, 30% congenital heart disease can be present, so we can do echocardiography, abdominal ultrasound we do because gallstone or renal anomaly, these are the complication can be developed. And fundoscopy we can do to check the papilloedema because it differentiated from Lawrence-Moon-Bidel syndrome, which is associated with retinitis pigmentosa. Now, what are the management of Prader-Willi syndrome? Management, first I would like to complete history, complete examination, investigation. Child if in distress, then admit breathing difficulty, this type problem, or acute cholecystitis, severe obesity, psychiatric problem, then if needed I will admit. Then it is a multidisciplinary team approach for Prader-Willi syndrome management. I involve pediatrician, pediatric endocrinologist, local child development team, geneticist, dietitian, ophthalmologist, psychologist for cognitive behavior therapy, IQ assessment, pulmonologist, cardiologist, and hepatologist, gastroenterology, surgeon needed, ENT also because obstetric sleep apnea can be developed, pediatric surgeon, these are. It is a multidisciplinary team we involve. And endocrinologist, we know that because there is diabetes can be included. Now, managing the weight and diet. The treatment also managing the weight and diet. I advise about the diet. What are the advice we give the diet? Start to get into good habits with a healthy diet and regular meal times as soon as child starts on solid food without waiting for them to show signs of an increased appetite. Then avoid sugary items, sweets and high calorie snacks. Give smaller portions of carbohydrates such as potatoes, rice or pasta. Increase the amount of lower calorie items such as vegetables, salads and fruits. Giving a vitamin supplement. Now, advise parents to control their food intake by. What are the advice I give to control food intake? Number 1, keep to regular meal time and not allow any extra portions. Number 2, stop them accessing food outside of meal time. Parents may need to lock the cupboards and the fridge or lock the kitchen and to make sure they can't get food from the bins or freezer. Number 3, to keep food out of their view. Number 4, to make sure there are no times they can access food unsupervised. Number 5, to make sure everyone who is in contact with the child, school staff, relatives and friends knows about the issues with food. And number 6, is also important to let relatives, friends and other parents and teachers know about the need to restrict the child's diet. Some medications have been used to try to suppress the children's appetites but have all been unsuccessful. So what are the medication we can use? We know that metformin, then or listed we can use. Weight loss surgery is not recommended for children with Prader-Willi syndrome because they don't have the willpower to stick to the strict diet required after surgery. Now, exercise. What type of exercise in Prader-Willi syndrome we can manage? The children should do at least 60 minutes of exercise a day. Many children with Prader-Willi syndrome have reduced the energy levels. It may be a good idea to break down their exercise into 5 to 10 minute sessions throughout the day to stop them getting tired and discouraged. Children with Prader-Willi syndrome usually prefer individual activities to team sports such as swimming, walking, exercising in the gym. It's important not to promise food as a reward to encourage child to participate in exercise because it can encourage unhealthy behavior. Now, what are the hormone treatments we give in Prader-Willi syndrome? Treatment with an artificial version of the human growth hormone, HGH, is usually recommended for children with Prader-Willi syndrome. We know that growth hormone we give Prader-Willi syndrome, Turner syndrome, growth hormone deficiency, these are. So, this human growth hormone has a number of other important health benefits. What are the benefits? It is increase the muscle size while lowering the amount of body fat, increase the muscle strength which helps with developmental progress such as walking and running. And this growth hormone should increase energy levels which will help the child to become more physically active, helps normalize the facial appearance, making the distinctive facial features associated with Prader-Willi syndrome less noticeable. It's usually recommended that treatment with human growth hormone begins during early childhood for 6 months to 2 years and would normally carry on until the end of growth. Sleep study is normally done before starting the growth hormone. Somatotropin is given by daily injection. Most children tolerate somatotropin and side effects are uncommon. Replacing male sex hormone testosterone is more contentious, although this will encourage development of puberty and build muscle strength. It's possible that some behavioral problems will be exaggerated. So this is the whole management portions. Now, we know the two type of pubertal delay, that is hypogonadotropic hypergonadism and hypergonadotropic hypogonadism. So hypogonadotropic hypergonadism is that Prader-Willi syndrome and Kallmann syndrome. Remember, these are brother and sister. And hypergonadotropic hypogonadism we find in Turner and Klinefelter syndrome. That's why Prader-Willi syndrome and Kallmann syndrome there is temper tantrum associated, because growth hormone is brain secret less hormone, hypogonadotropic there. Another, we give the growth hormone. How long we give? That is before 3 years we actually not give growth hormone, because wait for the catch up growth. And after 3 years we give the growth hormone. In mid puberty, because after bone ossification the growth hormone has no any role. When we give the growth hormone, endocrinologists check the bone age. How? The left wrist joint 8 bone we check the ossification center. If this 8 joint ossification center already come, then there is no any role of growth hormone. And complication of growth hormone, we know problem in liver, hypertension, idiopathic any headache. This is growth hormone. Now, what are the complications of obesity can be developed? This question. So, complications of obesity, we know diabetes mellitus, fracture, SUFI, sleep upper femoral epiphysis develop, hypercholesterolemia can be occur, obstetric sleep apnea, there is breathing difficulty, that is Piquian syndrome, that is severe associated with. Then gallstone can be developed, low of self-esteem, bullying, there is a vision problem, that is because of chronic compression of the optic nerve, that's why vision problem. So, these are the features of also complications of obesity. So this is all about Prader-Willi syndrome video station. Please do subscribe and share. MRCPCH with Dr. Emma Choudhury. Thank you.